Deep vein thrombosis is usually a common disease, although it's often asymptomatic. The deep veins of the lower limbs are affected most commonly, but thrombosis may affect other sites, including the upper limbs, intracranial, and splanchnic veins. Complications include pulmonary embolism, pulmonary thromboembolism, which can be life-threatening, and is therefore essential to have a reliable method of establishing the DVT risk of patients, and also to take active steps to provide prophylactic treatment as necessary. The common risk factors include obesity, smoking, prolonged immobility, for example, bed rest, long haul flights, and also major surgeries like orthopedic, abdominal, and even pelvic surgeries too. Pregnancy and puerperium after cesarean section, malignancies, inherited blood disorders, estrogen therapy, and medical conditions, for example, congestive cardiac failure, myocardial infarction, nephrotic syndrome, stroke, and systemic lupus erythematosus. In cases of confirmed DVT, treatment with anticoagulants must not be delayed unnecessarily unless there are significant contraindications to their use, such as recent intracerebral bleed, severe liver disease, active peptic ulcer, bleeding disorders, and severe hypertension. So the causes include stagnation of blood in the vein, an increased viscosity of blood, inflammation of the blood vessel causing the damage. The symptoms are swelling or firmness of affected limb, usually unilateral, and the pain in the affected limb, mild fever. So the signs that are usually elicited include swelling of the affected limb, differential warmth, tenderness, redness, pitting edema, and prominent superficial veins. Okay, let's look at Wells scoring for DVT probability. The Wells scoring for DVT probability objectifies clinical suspicion of DVT risk and provides criteria for initiating the treatment. So the presence or absence of the clinical features are computed to give a pre-testing probability score for that particular patient, which is used to prioritize investigation and treatment. Okay, so let's look at the point. So paralysis or paresis or even recent orthopedic casting of lower extremity, you give 1 point. Recently bedridden, more than 3 days, or major surgery within the past 4 weeks, 1 point. Localized tenderness in deep vein system, 1 point. Swelling of entire leg, 1 point. Calf swelling 3 centimeters greater or 3 centimeters greater than the other leg, you give 1 point. That's measured 10 centimeters below the tibial tuberosity. Also for pitting edema greater in the symptomatic leg, you give 1 point. Collateral non-varicose superficial veins, okay, so you give 1 point. And for active cancer or cancer treated within 6 months, you give 1 point. Alternative diagnosis more likely than DVT, like Baker's cyst, cellulitis, muscle damage, superficial venous thrombosis, post-phlebitic syndrome, inguinal lymphadenopathy, and external venous compression, you give negative 2 points. So let's look at Wells score interpretation for DVT. Between 3 to 8 points, that's high probability for DVT. 1 to 2 points, moderate probability. Negative 2 to 0, that's low probability. For low probability, D-dimer test is recommended. Low pretest probability combined with a negative D-dimer test essentially rules out a DVT. Moderate or high probability D-dimer test with additional Doppler or compression ultrasound scan is recommended. So investigations, as said earlier, D-dimer test is recommended. Doppler ultrasound, thrombophilia screen, for example, protein C for protein S levels in patients with recurrent DVT, and also FBC. The main treatment objectives are to prevent clot propagation and pulmonary embolism, to prevent recurrence. The non-pharmacological treatments: avoidance of prolonged recumbency and dehydration, avoidance of excess amount of coffee, tea, and alcohol, especially on long journeys. Increase water intake during long journeys or periods of immobility. Regular exercise during long journeys, for example, stopping on road journeys to take a walk or moving about on a plane during long flights, and leg flexing exercises while seated. Also avoid crossing legs for long periods on long journeys, and the use of elastic compression stockings. Pharmacological treatment. For Dvt prophylaxis, the first line treatment, you give heparin SC, that's subcutaneous, for adults 5,000 units 8 to 12 hourly. For children 1 month to 18 years, give 250 units per kilogram 12 hourly. The second line treatment, you give enoxaparin SC, adults 40 milligrams daily, and for children 2 months to 18 years, you give 500 microgram per kilogram 12 hourly. The maximum dosage of 40 milligrams, and from 1 to 2 months, it gives 750 micrograms per kilogram 12 hourly. Okay, for Dvt treatment, the first line treatment, you give heparin SC, 1 month to 18 years, 250 units per kilogram 12 hourly. Or you can give heparin IV for adults, 80 units per kilogram starts, and continue with 18 units per kilogram per hour. You can give 250 units per kilogram SC, and you continue with 250 units per kilogram 12 hourly. For children 1 to 18 years, you give 75 units per kilogram start. You continue with 20 units per kilogram per hour. 1 month to a year, you give 75 units per kilogram start and continue with 25 units per kilogram per hour. And neonates, 10 babies, you give 75 units per kilogram start and continue with 25 units per kilogram per hour. And neonates less than 35 weeks, you give 50 units per kilogram start and continue with 25 units per kilogram per hour. Second line treatment, you give enoxaparin SC in adults, 1.5 milligrams per kilogram, that's 150 units per kilogram daily. And with children 2 months to 18 years, you give 1 milligram per kilogram 12 hourly. 1 to 2 months, 1.5 milligrams per kilogram 12 hourly. For neonates, 1.5 to 2 milligrams per kilogram 12 hourly. Or you can also give dalteparin SC. Okay, so for dalteparin SC in adults, you give 200 milligrams per kilogram, as with a maximum dosage of 18,000 units daily. And for children between 12 to 18 years, you give 200 units per kilogram once daily, the maximum dosage of 18,000 units daily. And for 1 month to 12 years, give 100 units per kilogram 12 hourly. For neonates, 100 units per kilogram 12 hourly. And for warfarin oral, adults loading dose for day 1, you give 10 milligrams. For day 2, you give 10 milligrams, and day 3 you give 5 milligrams. And also you check the INR in day 3. So warfarin is not to be given in pregnancy. You continue 5 milligrams daily INR until a target INR of 2 to 3 is achieved. After this, the low molecular weight heparin is stopped, and the maintenance warfarin dose of 2.5 milligrams to 5 milligrams. Some patients may require 7.5 milligrams. It continues. So this continued under guidance at all times by a target INR of 2 to 3. So long-term treatment requires continuation of warfarin for 3 to 6 months, and if the risk factor is temporary or unknown, you still continue. So recurrent DVT and permanent risk factors such as thrombophilia may require long-term anticoagulation. Referral criteria: so refer to physician specialist for management and monitoring.